Hey, everybody. So, today's episode, I have the pleasure of interviewing one of my former graduate students, Miss Hannah Patten, who is now the teacher. And I know I've said it before, but I really think that's the whole purpose of becoming a clinical supervisor. We pour in the knowledge that we have at the moment and our attempts to serve those that we've been called to serve, but also to pay it forward for the next generation of clinicians and colleagues so that they can build upon our building blocks and go crush it in the real world. And that's exactly what Hannah has done. So, Hannah is out at Mayo Clinic and she works with some of the most complex itty bitties that come across their literal threshold. And I hope that y'all enjoy the episode and the knowledge that she has to share. Now, also, I would be remiss if I didn't talk about what is going on in the world this week and how you can take actions. So, literally a week ago, the special education offices at the national level were gutted by our uh, current political state of affairs in the world. This terrifies me not just as a clinician, but also as a human and as a sister-in-law, because I have Uncle Matthew who has an IEP at 48 years old because he falls in the IDEA Part A. And it feels like the carpet got pulled out from under all of our feet, even Miss Waffles here. So instead of sitting back and woe be unto us, here's what you can do. Please, if you don't do so already, there's a couple of accounts that you can go follow. The National Down Syndrome Society Conference, the Exceptional Children's Organization, the ARC. And in these organizations, they have specific links and resources, pre-populated letters that you can provide to your representatives, your congresspersons, um, to talk about why we as a profession need this federal office to stay open so that it protects the rights of those that we serve. As well as ensure that there's continuity in care when IEPs and IFSPs travel across state lines, that we're offering the best, most current evidence-based practice, and to ensure that children and individuals with adults with disabilities, that their FAPE is not violated. So I am also aware that there was a stay in the orders for the 460, 70 jobs that were lost there, but that is anticipated to be appealed. So please, if it's in your heart to take action, then take action with us. And a great starting point is the National Down Syndrome Society, if you need a starting point. But on that note, I really, really hope that you enjoy today's episode. I'm trying to help Waffles get out. And I'm off to record another one. So enjoy. All right, folks. So I'm having like a full circle Mama Bear SLP moment because today's guest, and I'm not going to cry, but I will get a little misty eyed, I am so personally proud of because a lifetime ago, I had the honor of torturing her for a semester as her clinical supervisor at a very teeny tiny little practice. And she asked the best questions and the most meaningful conversations in the car between patients at the clinic. And it was great. So I am incredibly proud. And Juliana, I know you're listening too, but like, look at all of our speech babies. But this is none other than Hannah Patten. And she is a phenomenal speech language pathologist out at Mayo Clinic. So very, very, very far away from Columbia and Lexington, South Carolina. And she is doing huge and amazing things in the world of pediatric speech therapy, especially for those with brain injury. and knew us a lifetime ago when Goose and Bear were like knee high to a grasshopper. So that's been a minute, but hi.
Hi.
How are you?
Oh, I'm doing great. That was such a nice introduction. I got a little teary-eyed too. Yeah.
Oh, honey, you have done amazing things. Um, so you and we were together when I think Goose and Bear were like 2 and 4. You were a grad student?
Yeah, that sounds right. I've been out of I graduated from USC about 9 years ago. So
Yes. Yeah.
timelines. Yeah.
That's a long time ago, honey. And what I remember is you always had the healthiest lunches. And I felt so guilty because like it was neat to see what everybody packed, like, feeding therapy, like to see what everybody packed in their lunches. And you always ate so healthy. And I'm like, okay, so I've got like chicken nuggets because that's what was left over after making the kids breakfast.
Probably pretty healthy, but I'll eat chicken nuggets and things like that too. I'm still 7. I love some fried chicken. So good
Yeah.
times.
Oh,
Yeah.
oh my goodness. Okay. Well, for folks who don't know you, please tell us your walk. How did you
Yeah.
find out about speech therapy and then end up a Gamecock?
Yeah. So I'm Hannah Patten. I originally went to school at the University of South Carolina and was majoring in ballet. I was a ballet dancer, and that was kind of my main interest. And so for the first 2 years of college, I was doing a lot of ballet. I was double majoring with English. After my sophomore year, I got a little bit burnt out on that and figured out that I needed to do something different. My mom is a special education teacher, and she had always kind of told me that speech therapy was a great job and she thinks I would be good at it and all of these things. I always had liked kids and kids with special needs. And so I took a class and really liked it, ended up adding it on as a minor. I started working in a lab with one of my professors, Dr. Suzanne Adloff, who studies dyslexia and specific language impairment and word learning. And she really supported me in applying for some undergraduate research grants. I was involved in some projects with her studying word learning. Um, I then ended up deciding to stay at USC for grad school, and I continued to work in her lab. As I got into my clinicals, I got a lot more interested in the medical side of our field. And so I knew pretty early on that that's what I wanted to do. I was part of USC has a neurogenic track where you have more of a medical focus. And so I did most of my external clinical practicums in acute care hospitals, an Army hospital, a VA hospital, and then with Michelle at a private practice in early intervention. And then I did my final externship at Children's Healthcare of Atlanta in acute care and in the NICU. And then after grad school, I went on to do my clinical fellowship at the same VA where I had been a student in Augusta, Georgia. And I was learning a lot about head and neck cancer and just acute care in general. We had a big spinal cord injury unit, also saw brain injury patients and outpatients. So I got a really good wide range of experience there. And then the VA fellowships are really just like a 1 year training program. So I went, after that was done, I ended up going back to Atlanta, which is, I'm originally from the Atlanta area. And I worked at Children's Healthcare of Atlanta for 5 years, primarily in inpatient rehab. So I was seeing a lot of kids with brain injuries, birth to 21. I did also work in acute care some, and I also kind of continued to maintain some adult patients. I worked PRN at a big level 1 trauma center in downtown Atlanta. And then after that, I, for personal reasons, ended up moving to Minnesota and Mayo Clinic. When I came to Mayo, I initially was working with adults and peds, and now my caseload is primarily pediatric. I currently probably spend the majority of my time in the NICU and then also in our PICU and cardiac ICU and general medical floors. And then I also work as part of our aerodigestive clinic. It's a multidisciplinary clinic that sees kids with complex feeding, swallowing, airway problems. So yeah, that's me.
That's I'm just saying, it's quite the CV for somebody so young. So like, huzzah. And I'm that's I'm so freaking proud of you, honey. Yay. Um,
Yeah.
Okay, so every summer, the American Board of Swallowing and Swallowing Disorders has a summer pediatric series, right? They also do the adult series, but let's be honest, those bookers are too big for me. So I enjoy the tiny human version. And so, and it's neat to see the theme, right? Like what's curated, because like each year there's a curated theme. And so this year it was neuro, basically, in a nutshell. And God, they're really good. And they come out in the summer, but you can take them year round. So go take a peek. There's, I think, 4 in the series, and then the live webinar, or 3 in the series, and it's 4 in the live webinar. But I sign up for it, and there you are. And I'm like, oh, sweet Mary Mother, this is amazing. So it was, I'm just sitting there and I'm taking the class and I'm texting Hannah, and which is so funny because I have all of y'all saved in my cell phone, and it's just, it was lovely. But your course was brilliant, and it was about pediatric brain injury. And I was like, this is lovely, because let's be honest, this is not something that's really covered in the world. Okay, rephrase. ASHA has to adhere to the big 9 in order to get everybody through. Accreditation programs have to meet CAA, Council of Academic Accreditation standards, in order to adhere to ASHA supporting the big 9. So unless you have a neurology class or a child language or a peds dysphagia class where they tiptoe into dysphagia, feeding, language acquisition difficulties after a brain injury, you're not going to find it. But folks, if you're listening, this is why we have to obtain CEUs. You can't just graduate and then think you know it and continue to practice the way that you were trained a number of years ago. You you keep growing. And so that's what brought us here today, because there is the certified brain injury specialist course that I know Renee Garrett, she is an adult SLP. I know that she has that. There's a couple other that have it, but this seems like a great course to kind of get the foundations, especially for those that want to go on for their CBIS. But is that something that you've thought about doing, honestly?
I actually I have my CBIS. I recently did one at LAPS, but children in Atlanta at Children's Healthcare of Atlanta, because that was such a big population for us. They facilitated us all, anyone who was interested in going through the course and taking the test. So, yeah, it is a good thing to do if you're interested in this population. And that was one place where I learned, I think, a lot. And it is more adult focused. There was some pediatric discussion, but just about like general, and like legislation, and all of the other things that affect patients with brain injuries, like the psychological components. And so, yeah, that training course is definitely beneficial. Yeah.
Yes, that's
Mhm.
that is perpetually on my to-do list. But you know what? Sports are expensive, and that's where my mommy money goes right now. Well, take us
Mhm.
from the top. What are the most common pediatric brain injuries that you really see, that you encounter? Um, and let's go there.
Yeah, so I would say that brain injury in both peds and adults, you can break it down into 2 kind of bigger categories. So that's going to be non-traumatic injuries and then traumatic injuries. In terms of non-traumatic injuries, that's going to include strokes, any sort of like CNS infection. There are a variety of different autoimmune conditions that can affect the brain and cognition and swallowing and cause neurologic injury. You also may see patients who have an anoxic injury. So that could be from like if they have a cardiac arrest and their brain goes without oxygen for a long time, if they have a big seizure and that causes them to go without oxygen for a long time. Seizures are kind of considered a non-traumatic brain injury, both a symptom of a brain injury, and they can cause a brain injury if they're uncontrolled and just as they continue to happen. And then the other big, and tumors also are technically considered a non-traumatic injury, although sort of different. And I won't necessarily talk too much about brain tumors in this, but when you think about function, they may have look similar to a child that has any other type of non-traumatic brain injury, and also, you know, the surgical procedures that are involved in it can cause secondary damage. They may have a stroke after their surgery. There are a lot of, they may have seizures. So that category is a little bit complicated. And then we think about traumatic injuries. So for traumatic injuries, that can be broken down further into open and closed injuries. And these may happen because of a motor vehicle collision. You know, a open brain injury would be maybe something like a gunshot wound. And then another cause of traumatic brain injury that's pediatric specific is abusive head trauma or shaken baby syndrome. And unfortunately, that is one of the more common causes of brain injury in kids. The most common cause of TBI in children is fall, and that's in kids under the age of 4, typically.
I would think car accidents and sporting
Mhm.
events.
Yes,
Yeah.
sporting events, concussions, football injuries, those
Yes.
types of things, definitely.
Yes. I mean, let's be honest, Pack Dawson, we are not making football players over here, as Goose loves chess. But he came home from school and he goes, Mom, because he runs cross country. He's like, Mom, the football players are all out there. Don't they worry about developing CTE? And
Yeah,
baby, very few seventh graders know about CTE or fret over CTE. This is
that is
so
correct.
no. But
A lot of ATV accidents that we would see, that's a big one. Any sort of like unhelmeted vehicle they could be riding on potentially could cause a TBI. Um, there's usually an uptick in that in the summer when people are outside doing activities. So yeah, a really wide range.
okay, one that I'm curious about is you
Mhm.
said autoimmune could be a
Oh yeah.
non-traumatic
Mhm.
brain injury.
Yeah.
Okay, I'm thinking like Lyme's disease because
Potentially, because you can have neurologic Lyme. The one that I always think of, or the ones that come to mind the most, is there's a condition called anti-NMDA receptor encephalitis.
wait, say
That
that again.
anti-NMDA receptor encephalitis. It's the Brain on Fire. There was a book and a Netflix movie, I think, a couple of
Yeah.
years ago. So that's a condition that we used to see fairly regularly where I worked in inpatient rehab, and we do see it here too. It most commonly affects adolescent women, and there's an association with ovarian teratoma. And a lot of the time, they initially start presenting with like psychiatric symptoms. It may look like some sort of onset of mental illness, which also often is going to occur at that same kind of time frame. You know, later teenage years. And then as they continue to worsen, they may have a seizure or something that may kind of cause it to be apparent that it's not something psychiatric. And then the range of severity can be really, really dramatic. Some patients have really severe psychiatric symptoms, and then some may be more like catatonic or and more disorders of consciousness type presentation. And then um, it's treated similarly to other autoimmune conditions with IVIG or plasmapheresis. Um, but detecting it can be challenging. And I think if it's not something that you see a lot, it can be kind of shocking. Because of where I had worked before, had seen a lot of it. And so sometimes even here, when we get a patient that has it, I'm like, they're going to have anti-NMDA because the presentation is a lot of the time very similar. Um, yeah, that's an interesting one.
I love how I don't know if you've seen it, but have you ever noticed there's like patterns in your career and your
Oh
caseload?
yeah.
Yeah.
Absolutely.
Yes.
Absolutely.
Like I have a special right now on undiagnosed or in process EDS. Like who would have thought Ehlers-Danlos? But one of the physical therapists that I work with, Teresa, made the comment. She goes, honestly, she goes, it was there. We just didn't have a diagnosis for it. But these kids were there. It's just people are talking about the symptoms now. I'm like, yeah.
And that's sort of like what I think anti-NMDA. It seems like it's becoming more frequent, but I think people don't really think that it's more frequent. It's just that we're better at diagnosing it and figuring out when people have it, where before it may have gone continued to be thought to be more psychiatric. I've also seen kids that have lupus that end up with lupus cerebritis. That can be challenging and can cause really significant cognitive deficits. Um, but yeah, there are a lot of different. One of the case studies that I talked about in that course over the summer was another situation where a kid was having this really progressive dysphagia that was kind of of an unclear etiology, and it was even all of the testing was coming back negative, and there was even concerned that it might have been like a functional disorder. And based on her swallowing, I felt like very strongly that there was no way it was functional, because she had really, really poor relaxation through the cricopharyngeus. And I just, that's not something that we have a lot of volitional control over.
Yes.
If you're like contracting all of the other muscles to swallow and the UES is not opening, that to me is a pretty clear neurologic sign. And that patient ended up having a rare autoimmune disorder, and with treatment got better. So yeah.
Yeah. It's amazing how much we have to advocate for when we know there's something there, and how much you have to empower your caregivers to then be an advocate for their child, because in different pockets across the country, there's still so much bias in medicine. And hi, conversation for another day. How about that? Okay, so then with respect to peds feeding and swallowing or language, like where do you step in and like do a screening, do an eval for, a brain injury case?
Yeah, so I would say in my current setting, just with the way that things function here at Mayo, we get consults on patients really, really early. So either myself or my colleague typically go to rounds in the PICU every morning. And so these kids that are sick enough that they need to be admitted to the PICU, we usually are getting orders immediately, oftentimes before they're really medically ready for us to be involved. We'll get consults while kids are still intubated and just kind of monitor. We'll get consulted before they have a trach placed so that we can do some education beforehand with the family. And so we definitely evaluate patients very early. We have a pretty robust disorders of consciousness program here too. And so we do the coma recovery scale with some of these patients if they have more severe brain injuries. And that, as long as they're not sedated, we may even start doing that while they're still intubated. I recently, within the past couple of months, had a PICU doctor ask me to go do a swallowing evaluation with an intubated patient, which was a new one. But it wasn't
Wait, what?
really, it wasn't really that's what they wanted. It was that there was a lot of concern that the patient didn't have a gag reflex, and they were trying to kind of understand more about that, and knew that I may be able to help them answer that question. And so that was a new one, but we definitely get involved very, very early with patients here to start education and doing as much as we can. Not typically for dysphagia, more for CONCOM when they're intubated, but yeah.
I had somebody tell me one time, a third of the population doesn't have a gag reflex,
Right.
and they kept pushing, 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 and the individual was like, "Hey, that's why we have porn stars," and I was like, "Ooh, oh, but you're not wrong." But I was like, "I don't think you can say that in public," but like, I was like, but you know what? I have used that line to try to explain, but like, it's also just normal. Some people just don't have a gag. I mean, you
Yeah,
know.
I think in this situation, the patient had like a pretty significant tonic bite reflex, and I think that the residents were having a hard time kind of figuring out what to use to test her gag reflex, and so I ended up bringing a maroon spoon, which if you've most feeding therapists probably know what that is. It's a very thick plastic spoon that if they bite it, it's not going to break a piece off or anything like that, and so it ended up being helpful. But yeah, we get involved really, really early. I think that the most important thing with this population, especially in the acute care setting, is that, the decision making is not something that we're kind of doing in isolation. It's very multidisciplinary. And so a lot of it is driven by the medical team. One thing that I really like about working at Mayo is that our PEDS group is small. Mayo Clinic is a huge hospital, huge health systems, but our pediatric part is quite small. So the providers that I work with, I know very well. I know the residents well that we work with for the most part. We have very close relationships with our ENT and pulmonology and GI colleagues, as well as kind of the intensivists. And so a lot of the, when do we start trying to feed the patient? When are we doing these things is something that we kind of decide together based on their overall medical status. One thing that I think about with kids who have an acquired brain injury and were typically developing before is that they may not have those same like risk factors that you would think of as a kid who has really bad lung disease or really bad or a congenital cardiac disease that may make them at a higher risk to get sick from aspirating. And so with this acquired brain injury population, because the majority of the time before their brain injury, they were relatively healthy, we are usually a little bit more aggressive with starting to try to feed them. I think there's a lot of benefit in introducing some oral intake, even if it's in small amounts or limited early on, just to help kind of normalize their environment and let them have something to kind of work on. And so, yeah, we get involved really early and kind of start doing some clinical assessment.
Have you read the book Every Deep Drawn Breath?
No, I have not. Yeah.
Oh, it's just out of reach on my. I've been reading this book for like a year
Yeah.
and a half. Like I pick up a chapter and then I put it away and then I pick it up.
Mhm.
It's actually written by a ICU, I think it's a pulmonologist out of
Mhm.
Vanderbilt.
Yeah.
And it's written for adults, right? But what he talks about is just what you said, how you have
Mhm.
to normalize it, like how you have to introduce PO and like quality of life as soon as possible so that the old you lose it, you don't use it, you lose it. And but it's a really, really good book. I think you would
I
also, he
probably would
talks.
like
Yeah, you would. Ellis, Eli, I'm gonna grab it, but I'll send you a picture of it later. But he even talks about how like evolution of care and ICUs have changed and he started in New Orleans and then traveled up to Vanderbilt. It's a spectacular read. Um, Actually, I think Renee interviewed him on her podcast. I'll have to double check that one. But it begs the question, where did you go to learn to feel comfortable? Because you're talking about advanced skill set in etiologies and treatment, but then also the rounding, the interprofessional practice is based off of interprofessional education, like learning about those different disciplines, and that's not really taught. So like, how did you grow your skill set?
Yeah, I think that I have been very fortunate in my career to spend most of my time working in these pretty big academic medical centers where I have really close access to these other providers and can ask them questions. And I think it's helped me to really recognize like when I don't know something and when I need to rely on their skill set. Um, I think that, there's a lot of continuing education out there in terms of learning about brain injury, not as much that's pediatric specific. And so I think that with this population, you have to kind of do a lot of adult continuing ed about just brain injury and what happens to the brain when it's injured, and then try to combine it with pediatric knowledge and just knowledge about child development. And then things that we kind of know about kids who have brain injuries that do make them different from adults. One thing is that I think that one of the kind of take home points about working with kids who have a brain injury is that there used to be this thought that if they were injured when they were younger, that they may just recover from it more easily. But what newer research is showing is that actually, because they didn't have these pathways for all these skills built yet, that it may make it harder for them to acquire new skills. And
Mm,
so that's kind of the main thing to think about with this population.
that's a
But yeah, I
huge
think,
shift. That's
yeah.
I saw some of those articles come through actually on LinkedIn of all places. But it was wild because it was, neuroplasticity within the first 12 months for children is supposed to be like exemplary
Yeah.
comparative to like a 60-year-old. And yeah.
Yeah. And I think in terms of the IP, the interprofessional kind of education and practice question, I think that um, part of that is myself and my colleagues here are very comfortable walking up to a doctor in the ICU and telling them what we can do and why we should be on the team and how we can help the patient. And so then I think that that in itself leads to conversations. I think that sometimes SLPs, because we're not physicians, are intimidated by talking to doctors,
Yes.
and I think that they want to have everyone on the team who can possibly help the patient. And so I think just being comfortable going to them and advocating for your skill set and what you can do and how you can help the patient is the best way to kind of build those relationships. And then as they learn about what you can do, they want us to be part of the team and appreciate us being at rounds and being there to kind of help move things along with these patients. And there's a big focus just in ICU literature in general about early intervention, and so the physicians know this, and they know that having therapy involved early on is of benefit to the patient. And so, yeah, I think the biggest barrier is just being confident enough to walk up to the nurse's station or to where the physicians sit and just talk to them.
Yeah. Yes. But that's terrifying. I mean, heavens to Betsy's. Like, I knew my team and my tribe of doctors back in South Carolina, but then coming from Columbia, where I'd practiced for like 12 years, starting over fresh, it was like, well, you can't just like pick up the phone and then start all over again. It was building building relationships, making those, meaningful moments. Yeah, and that's hard. So do y'all have a set protocol when they're inpatient on the evals that you use for feeding for language, or do y'all extrapolate a little bit?
It's very informal, and I think there's so much variability just depending on the patient. I think in terms of like cognition and communication, that starts out very, very informal. If it's a patient that has disordered consciousness, then we are doing the coma recovery scale pretty early on. Um,
Can you
it,
explain what
yeah,
the coma recovery scale is? Like, talk about that for.
so, yeah, disorders of consciousness is this population of patients with more severe brain injuries who are going to have reduced awareness of their environment and also sometimes reduced alertness. So, we do this assessment that looks at many different skills and how the patient can respond to things in the environment. So it's looking at their auditory response, their visual response, if they have like functional object use or how they can their motor movements. It looks at oromotor function and then communication, and helps you to determine which of these kind of states of disordered consciousness the patient may be in. So the three different states of DOC is a coma, where the patient doesn't have a sleep wake cycle, their eyes are closed, and they are not responding to anything purposefully in the environment. A step up from that would be unresponsive wakefulness state, or what people used to call vegetative state, where the patient will have a sleep wake cycle, and they may have some reflexive responses to things in the environment. So, like if you pinch their finger, they may posture, but they're not having any purposeful interaction with their environment. They may have spontaneous eye movement that's not purposeful. They may have spontaneous oral movement that's not purposeful, but nothing that is clearly intentional. And then a step up from that is minimally conscious state, and that's where the patient may have some purposeful responses and some not, and they may really fluctuate a lot in that state. And then after that, they have moved on to just fully conscious.
Um, as you're describing that, I'm going through like different scenes because I don't work inpatient. I've never wanted to work inpatient. My heart can't, like, I can't do it. So thank you for doing it for us. But you say functional object use, and I'm
Yeah,
seeing Ariel from The Little Mermaid using a fork as a hairbrush. And
that's
like,
exactly correct. Yeah.
yes, but like
Mhm.
that's the analogy that goes in my head. And then when you're describing the states of consciousness, I'm seeing Kill Bill, which you're probably too young to remember. But like she has a whole scene where she comes out of her coma and then she yells at her big toe to move. But
Yeah.
like, yeah, that's so
People
folks.
never
technical to non-technical. You're welcome for the analogies.
Yeah, I think families think that people wake up from a brain injury in that kind of movie way, and it's usually a lot more gradual. And this assessment is really important because we're looking at these really, really subtle changes in behavior that are meaningful. And so I think sometimes, I had a patient recently who our ENTs that I work with were really involved, and I would go and see the patient and say, like, oh, I think she's like following some commands, and they'd be like, no way. And I was right. Because we're looking at these really, really subtle changes, you do the assessment with two people. So we bring two therapists, whether that's two SLPs or a PT and an SLP or an OT and a PT, and you're looking at it in a really systematic way. And the criteria for if the patient gets credit for an item is really specific. But it's important because when you think about a lot of these patients that have really, really severe brain injuries where they're discussing like goals of care, it's important that we're giving the family accurate information about what we're seeing. And we can never say, no huge medical decision should be based on this assessment alone, but it can be a piece of helping the family make decisions about what's best for their family member. And so, yeah, I think it's a really important part of our practice, and really important for making sure that families have a good understanding of what their child is actually doing.
Yes, that's
Mhm.
um I don't know if you knew it or not, but Goose had a horrible concussion between kindergarten and first grade. He was roughhousing with some kids, and it was in aftercare over at the one of the private schools back in Columbia, and they put him in a headlock, doing WWE like wrestling moves, and twice, and they dropped him on posterior occipital, and he actually it was severe. Well, one we went to as a mom. Traumatic enough, we go to the emergency room. I took him immediately there. The resident tells me, I mean, he's got all of the concussion signs and symptoms immediately. And the resident said, boys will be boys, and he should just toughen up. So I told the resident to go grow a set and get me a real doctor. And then they sent me, actually, the chief pediatrics came in, and he was like, so this is what we would consider a moderate level concussion, and you're going to go to the concussion clinic. But it was so bad his eye actually rolled, so we had to go through OT for like visual motor integration and like get his little eyeball back in alignment. But um, we had post concussion symptoms for, I want to say, it felt like a year, honestly, like emotional affect changes. And I am so grateful for the OT that we saw, who walked us through, because she was really good at a unique skill set for emotional regulation as well as visual and motor integration, which those are, you don't always find an OT that has scattershot skills. But I use that as that took a long time to recover, and it was just a concussion. And I'm not belittling that in any stretch of the means, but what you're talking about, when they're with you inpatient, they're not going to be right as rain when they leave. So, like, what do y'all do for interventions? And then how do you transition to the next step?
Yeah, a lot of it is family education. And I think that the kind of hallmark of what you should be thinking about with brain injury patients is neuroplasticity. And so everything we're doing is thinking about how we can help their brain rebuild these connections and heal. And so, for example, like a patient who isn't following commands, we may over and over again facilitate them doing it over and over and over again. And it can feel to us kind of boring and repetitive sometimes, but because for the patient, it may take them so much cognitive and physical effort to wiggle their fingers or do whatever it is that we're asking them to do. Um, you know, that just repetition and doing the same task and helping them to do it appropriately as much as we can is the best thing that we can do for them. And that really applies, I think, to cognition and communication, and also to dysphagia and feeding and swallowing. Um, and I think that, I didn't really get into kind of what we do in terms of feeding and swallowing with these patients. I would say that, pretty early on, we're at least trying to start letting them have some small sips of water. And again, that's a decision that's going to be made with a lot of physician input. If the patient has a trach, or we know they have a paralyzed vocal cord, or we know they have something physical that's going to potentially increase their risk to aspirate, then we may proceed with doing some sort of instrumental assessment sooner. But I think a lot of the time there's a lot of benefit in just kind of letting them practice something. And, recognizing that we can never eliminate the risk of aspiration, but that the benefit of letting them do something is maybe more so than the risk that they're going to aspirate a little tiny bit of water or whatever it is we're giving them. If it's a baby, a lot of the time we'll start offering them like 5 to 10 mils of something from a bottle just to let them practice. And,
Do y'all,
sometimes I think
wait,
yeah.
do y'all have a breast milk bank there?
Oh yes, there's a very fancy breast milk lab in the NICU where they do all kinds of things
That's
with breast
amazing. I love it when I'm like, yes, all the
milk.
boobies. Okay, sorry,
Yes,
squirrel.
there's a
I was
whole
really
thing.
excited.
Oh, no, it's okay. Yeah, in our NICU, there's a whole area where there's a whole staff that manages breast milk, and yeah, it's pretty cool. So
That's,
yeah,
but
um,
if in the event that you were to aspirate breast milk, or if you were to aspirate water, the body is equipped to handle those two items. It's
yeah,
bacterial load, it's food, and objects outside of that can really kind of
yeah,
flip you down. But I mean, we all have a certain level of aspiration on a regular basis. And I think that's not necessarily, we got to remember that. Yeah.
yeah. And I could go into a whole tangent about our aerodigestive program and kind of how we manage aspiration. That could be a whole nother discussion that we're pretty passionate about here. That, the pulmonologist that I work with really, really closely feels very, very strongly. And I agree that, when you think about aspiration, there are people who aspirate, and then there are aspirators who have aspiration disease. And so when you think about that, yeah. So, like, when you think about someone who has like disease from aspiration, that could be lung disease, that could be a feeding disorder, that could be like failure to thrive. But if they are not having those things, then the aspiration doesn't always matter. And we can't determine that just from like clinical observation and testing. And there is a lot of research that shows that, like, just because a child's not getting recurrent pneumonia or having respiratory symptoms, that they're not having chronic changes to their lungs. The only testing that can really determine that is a bronch with a BAL, a bronchoalveolar lavage, where they take samples of the cells and look for inflammation. And then also a chest CT, where they're looking for a true lung injury, where that chronic inflammation causes bronchiectasis or scarring in the lungs. And so the way we manage our aspirating population here typically is that, we use an instrumental swallowing evaluation to kind of help determine what won't make the kid aspirate. And it is helpful in identifying physiology. But, if they have this whole pulmonary workup and we see them aspirating during the video swallow study, and all of their chest imaging is normal, and there's no obvious injury from it, then we don't change anything about their diet, and we let them keep doing what they're doing and continue to kind of monitor things. And so I think that we kind of don't um, we I think also, a lot of SLPs, physicians, everyone who kind of works with children and adults, aspiration is this big scary thing, but we can never eliminate aspiration. Even kids who have a G tube, they're going to throw up, they're going to aspirate that a little bit. And we may minimize the volume we give them. So we may only give them, 5 mils of breast milk from the bottle a couple times a day, with the thought that, if we give them less, there will inevitably be less that goes into their airway. But
But they're still practicing.
we're still
They're still
practicing.
learning those reflexes because you have these finite windows of neurodevelopment that we need to capture and build upon.
Yep.
So, yeah.
Yeah,
Yes.
very, very rare for me to make a child completely NPO
Yes. I
or an
just,
adult.
I, I mean, I had one night of pediatric dysphagia in my entire grad class, and it was
Yeah.
basically like if you aspirate, like you're
Yeah.
NPO, that's it. And
Mhm.
to see the literature and resources go all the way from like the beginning to
Mhm.
now, it's
Yep.
just okay. So then we need to claim this and ask your aerodigestive tract team and you to come back and do a second podcast because
We
that would
certainly.
be so cool.
Oh yeah. Well,
Yes.
I can definitely get some people to join. We love to talk about what we do.
Well, you
It's
should. You should be proud.
Yeah.
Yeah.
I really, even in, my almost 10-year career, have really shifted from like when I see a kid for an outpatient swallow study, if they aspirated everything, it used to be like, oh my gosh, we have to send them to the ED, they need an NG tube, they need this, they need this. Where now, when I see, unless they truly are like unwell and I'm concerned that it's not safe for them to keep eating and drinking, it really has shifted more to, I reach out to the PCP, I say, I think they need to see pulmonology. If I think they need to go through our whole aerodigestive clinic, we do that. But I think that not panicking is important because if all of those pulmonary tests are not done in the condition of what the patient is actually doing, then they don't mean anything. So if we have them get an NG tube and then we make them NPO, and then a month later they have this bronch while they've been NPO, all we know is that their lungs looked okay while they were NPO.
This is
So that's
I, no, I go down the rabbit hole of social determinants of health because this works because you're at like a huge center with like access to these teams. And then I go back to, we're tiptoeing into rural country and out here in Shenandoah Valley, like we're already looking at hospital closure because of the bill that was passed, or like even more limited access to care. But honestly, we're close enough to the West Virginia line that we still get patients that will cross the line into Virginia to get services. And so it's it's that access. So, okay, so folks, as I say all of this, I feel compelled to offer solutions for your team. So, Feeding Matters, who I'm a huge fan of, they have throughout the year they offer scholarships for second opinions, and it's $1,000 or $2,000 scholarship depending on how much funds they have. And they will, you can use that money to offset like the day to day costs of expenses, but also to get to a specialist. And at a lot of major healthcare facilities, I know Cincinnati Children's Hospital does a spectacular job of getting the referrals in, and you can stay at a place called like the Ronald McDonald House. So if you don't have it there and it doesn't feel like it's financially feasible, there are those resources available. So as we're talking about like best practice and what it looks like out in the like rural areas, we can still level the playing field because that is equity and why we should have equity.
Yeah, and I would say we definitely have similar challenges, where we are this big kind of destination medical center where a lot of people are coming to kind of get a second opinion, but we also serve a lot of the Midwest. A lot of my patients come from the Dakotas and very rural areas, Iowa and very rural areas where there are a lot less resources, and that does sometimes make it challenging to manage these complex patients. And we do the best we can. Like everything that I was just talking about is best case scenario. There definitely are times where I just have to kind of really rely on the PCP to help make a decision about what to do, because I think that that's another thing is that we as SLPs, we're looking at the physiology and trying to figure out what may be the safest thing for the patient, but the physician who's really managing their care is the main person who should be kind of putting all the pieces together and deciding what the most important thing is that has to be addressed.
Yes. But I love that you open with, I don't know if you can hear Waffles. She's
Yes.
supporting in the background. Yes. Waffles is excited. But
Yes.
it's teaming. You talk about the rounds. Like that is so imperative to care. We cannot practice in our
Mhm.
silos. But
Yes.
okay, so then that begs the question between I love interprofessional practice. Like I love that. But then it begs the follow-up question for intra-professional practice.
Mhm.
How I still see this ego of, oh, well, I work in this setting, so I'm a superior speech therapist, like on social media. And like people don't actually say it, but it's like this whole like image that you build for yourself on social media. And I'm out there posting pictures of my kids and food and floofy animals, right?
Mhm.
Quality items. But how we work together, because it is a continuum of care. But what does that look like, best case and worst case scenario upon discharge for y'all? For like, I don't know, a language case and or a feeding case?
Meeting. I'm always happy to talk with outside therapists. We are very, the way that Mayo sees a lot of our outpatients specifically, but also some inpatients who get transferred from a long way away, is that I may see them just for one visit. I may see them an outpatient just for to do a video swallow study and a fees, and that's it. And so I'm giving this plan, but it's really up to the person in early intervention or at a clinic or wherever the patient's going to be seen to carry it out. And I would always rather them email me or call me or reach out to me to kind of discuss it. And I'm happy to kind of talk through the things that I would be thinking about. I think that, I've
How does
spent
the therapist find you?
a lot
Was
of
that
the time I'll give the families my email address or my like a way to get in contact with me when they leave. We also are fortunate in some of our outpatient settings to have like care coordinators and things like that that can help connect us with the outpatient person. I think a lot of the kids that I see kind of more regularly who have outpatient or EI therapists, they are kind of wanting to talk to us, and the family is already coming to the appointment saying like, will you call the SLP after the appointment and talk to them about the swallow study or all of those things. And so I think that really the family is the easiest way to facilitate it, because they have the communication between both of us.
but that also puts it back on keeping the caregiver at the core of what we do, because we get that those moments and snapshots of time with them, but they're the ones that are putting it into action as part of their daily routine.
Yep, exactly. And I think that also just with all of these kids, having that like focus on caregiver coaching. And, I tell families this all the time in the NICU that I don't, there's nothing that I don't need to feed the baby. Like you can feed the baby, the nurse can feed the baby. I don't have a special skill to feed the baby better. I'm here to help you learn how to feed the baby safely and to look out for these different signs of something going wrong. But I think that in pediatrics, focusing on caregiver training has to be the like primary goal, because they are the person who's going to be caring for them long term. And me coming in for 15 minutes to see them in the ICU isn't what's going to make meaningful change. It's helping the family kind of understand things that they can be doing with them, and in terms of brain injury, talking about like maintaining the environment, not causing them to get too stressed out. There's so many different things.
Wait, translate maintaining the environment
Oh
for folks
yes.
who are familiar with this one.
Yeah, older or kids who have had a brain injury, their tolerance of stimulation is likely going to be a lot lower. When you see kids that are brain injured, or adults, they sometimes get agitated, they get overstimulated really easily. And so there's a big focus on keeping kind of a low stimulation environment, keeping the room quiet, trying to kind of have one person talking at a time, not trying to make them participate in too much activity at once, because that can ultimately make them shut down. And so there's a balance between helping the family kind of provide them appropriate stimulation without overdoing it. And it's up to everyone else there. I'm only there for a few minutes. It's a lot of education with the ICU and the caregivers. Mhm.
And that was something that I learned intimately with Goose when we walked through his healing. Like I remember, so our living room back in Columbia um, it was rather dimly lit. There, like the one window was up the stairs and house bells. We had that put in because they found mold in the wall after we bought the house. But we had to close the curtains on the one window. And he was, an active kid, 5 or 6, but it was several weeks of lower lights, especially after school when his brain had just taken a beating all day long. And he wanted to watch his shows, but the audio visual feedback, like, I mean, Team Umizoomi, and I'm thinking the little octonauts, aquanauts, those little guys, those cartoons are, that's a lot of bright flashing light. And so for us, it was okay, so we're going to have it playing in the background, but I want you to just lay with a damp washcloth on your face. And so he can hear it, he can participate it, but we cut down like half of the input for him. And those were just some of the strategies that, like, we were mentored by the OT, by the concussion clinic down at MUSC. I mean, things that I didn't, too many smells, and which is probably because, Goose's little neurodivergence at baseline. But like we have to watch her like smell
Yeah,
intake. Yeah.
yeah,
But those are maintaining an environment, and then slowly as his, I guess, threshold improved, we added a little bit more stimuli, but it was like this perpetual, like, how much is too much? When will we know? And it's like a sensory overload. You don't know until you know, and then you're screwed. And then you're like, ah, Brett, pump the brakes.
uh-huh, exactly. And I think that sometimes we do so much education and then the family almost like overcorrects, and then you walk in the room and it's always just dark and it's like,
Yes.
okay, we have to find a balance. Not like totally nothing, but not, constant TV music, loud, multiple family members, people in the room talking all the time. So yeah, there's definitely a balance, and it is nice when they're in the hospital because we just have such immediate access and can go do education kind of as much as we need to. But yeah, there's a lot of different things, a lot of so much of the acute and even into inpatient rehab piece of what we do for these patients is family education.
Yeah, that's so folks, if you're looking for a good resource to grow, how do we engage in caregiver coaching? Family guided routines based intervention, FGRBI, I think it's .com, it might be .org. So forgive me if I send you to the wrong one. But it's the brainchild of Dr. Juliana Woods out of Florida, and she has so many resources. She has since retired, and a lot of the work has been carried forth by Dr. Francis Burns, who's one of my mentors at Francis Marion University. But they have free videos, free tutorials, free trainings on how to ask meaningful questions, how do you frame this so that you understand the daily routine of the family with the child, so that you can then coach and guide. And then how do you, I don't want to say select the goals, but how do you balance caregiver input with your clinical knowledge on disease progression and or healing? Because you talked about the morning, or the morning, well, it's morning here, but earlier in the podcast about how, like, brain tumors are their own special breed. And so, and seizures are their own special breed, because let's be honest, some of our little ones that we are called to serve, their trajectory may not be up. Um, what do you do there? Like, also, how do you guard your heart, hun?
It's definitely a challenging thing, and I think that one of the neuropsychologists who I used to work with in Atlanta kind of said to me once, and it like really stuck with me. And part of this with that coma recovery population, I think this is when I really started to kind of understand this, that if I'm not honest with families, it's not for them. It's because it's to protect myself from feeling bad about it. And so I think I have to remember that, like, ultimately, it's not my child. I have to give them the right information so that they understand. And you do that in whatever way you can, and to be compassionate and not trying to just shatter their dreams. But I think that, in situations with kids who we know have something neurodegenerative or something that's not going to get better, I tried not to, um, tell them directly, we know this is going to get worse, but sort of talk about, like, as it changes over time, and you never know how quickly something may deteriorate. It can be, slower, and we can never truly predict. But I think that, yeah, that's kind of my attitude that I don't say anything in such a blunt way that it's going to upset them, but that I try to be as honest as I can. I think when we do that coma recovery test specifically, we're looking for these behaviors, and sometimes families are really thinking that the child's doing something that we're seeing they're not. And I'll tend to say, we're not seeing that right now. That doesn't, you're with them all day. That doesn't mean that you're not seeing it. If you see them, touch their nose when you tell them to, take a video of it and I'll look at it and see like what we think, and try to empower them to, they know their child better than I do, but also being realistic and not saying that I'm seeing them do something that they're not. Does that kind of make sense?
Yes, it does,
Yeah.
because I mean, you and I had some harder cases a lifetime ago, and early intervention, while I will do child led and play based and give hope, the little ones that tend to find their way to me tend to have a lot, which is, I love, right? I wouldn't have it any other way. But giving hope in that setting, and then also, if tiny human comes home from the NICU, tiny human comes home from the PICU, like we're in early intervention, or if they need home-based services because they're not stable enough to go to the schools, or the schools are not equipped to that, support them. I know there's advanced settings like PPECs down in Mississippi where they're physician prescribed extended care. And it's a school where they can handle trachs, vents. They have nurses for like a 1-to-1 ratio. Those are ideal. That's not, but it puts the onus on that therapist in early intervention to really understand and seek out what is the trajectory of this disorder, diagnosis, disease. And I used to recommend NIH or rarediseases.gov, but unfortunately, as government websites have changed and resources have been pulled, I have found that I go more and more to the nonprofits associated with those diagnoses, or to I hit the books for journals and just hope and pray that they're free access. Um, do you? How do you educate caregiver on those kind of things?
Yeah. I think that in terms of like a genetic condition or something, a lot of the time I do defer to the physician. So if it's like a neurodegenerative um, disorder, I try as much as I can to defer to, the neurologist, whoever it is, to talk about that prognosis. In terms of acquired brain injury, what I tend to tell families, because, when we see like an infant who has a brain injury, we can tell you what they're doing right then. But what I tell families is that, what I know is that they will change over time. We don't know how it will change. They may not have feeding difficulties. They may do great. You may never see symptoms of this, but we don't necessarily know. We can't predict the future. And so I empower them to just know that, like, as they're continuing to have to meet other developmental milestones, that they may not, and that that's something that will have to be like addressed at that time. And so I'll talk about things, in terms of feeding specifically. A baby who has had a brain injury may do just fine bottle feeding. I will say most of the time, um, you know, babies with a neurological injury often do silently aspirate, at least in my experience. And I almost always am going to do some sort of swallow study with them. But say they don't and they're able to discharge and they're feeding just great. I tell families, once it's time for them to start drinking from a cup and a straw and chewing, they may need a little bit more feeding therapy then, because it may be harder for them to acquire those skills. But we just don't know. And so the only thing we know is that they will change over time. And that we may just have to be looking out for these other potential challenges as they grow. Once they go to school, are they potentially going to maybe have a little bit of difficulty with attention? We don't know. They may not. But just kind of encouraging families to look out for those things, I think is a major thing that I tend to do. Um, and trying to make sure that they have some sort of person monitoring for those things. So, like, if it's a patient who's going to come back here, they would see our physical medicine and rehab physicians, but also like their primary care doctor can be a good resource if they're not going to be following with us to just help kind of monitor for their development. Mhm.
Yes. But that's where access to developmental pediatricians later on, access to counselors, not just for the child, but also for the caregivers, like making sure that caregivers have a safe foundation. And also, what I hear we're talking about is attunement and attachment. What is that caregiver's attunement and attachment with their child, with their infant? Like, are they learning to read these subtle cues? And in some of the acquired ones, those cues will change because what that little one looked like pre-accident could look very different post-accident. And the caregivers have to kind of learn those again. And that's, but we have to hold space for attunement and attachment and coach them through that. And that's a huge part of like maternal mental health and like infant toddler mental health.
Yeah, another challenge that I hadn't really talked about yet, but that just with this population specifically, is that sometimes kids who have had a trauma, like a gunshot wound or specifically like abusive head trauma, where there's a suspicion that whatever environment they were in before is no longer safe for them. Um, they may not be discharging with their parents. They may be discharging with a foster family. And then we're having to try to make sure we're educating the people who are going to be taking them home immediately, but we don't know what their long term kind of situation is going to be. And so I think that's also just another challenge that likely falls on the outpatient providers, because if they go home with like a grandma but then end up getting taken into foster care, well, that foster family didn't get any of the education that we did while they were in the hospital. And so that's, I think, another thing that's just challenging with this population specifically.
Yes. Yes. Oh, I've had several conversations with guardian ad litems lately, and that's yep. But that's hmm, again an acquired skill that you're not trained on in class. But
Yeah,
yeah,
and I'll say I think that the setting where I worked in Atlanta, that was so trauma heavy. I think, you know, the inpatient rehab unit where I worked is one of the largest in the country, and we admitted kids from all over the Southeast, and so we saw it was a lot of trauma that I think is unusual to probably see in such constant quantities in one place. So um, yeah.
yeah. But then it goes back to make sure you're taking care of yourself, because if we're not taking care of ourselves, then we're not good for
Mhm.
anybody.
Yeah.
Yes.
Yeah, I think pediatric acute care is something I always kind of knew that once I started getting more interested in the medical side of things, I remember when I started grad school, they made us write down on a little piece of paper what we wanted to be doing when we were done, and that's what I wrote. I said I want to work in the hospital at Children's Healthcare of Atlanta, and then they made us open it. And I was going there to do my externship, and I even remember when I was kind of saying that that's where I wanted to go. Juliana and Diane, who coordinated our practicums at USC, were like, it's really hard. Like, are you sure? And I said, like, no, I want to do it. I want to do it. But it is challenging. And I think that you know, you have to be prepared to see a lot of really, really sad stuff. Mhm.
Yes.
I think it sounds fun. It's babies, it's kids, but it can be very heavy.
Yeah. Yeah. Yeah, it can. But God, we need y'all that do this. So, for on this end, thank you very much for being you, because it's amazing to be on the receiving end, knowing that the tiny human had great care before, and I get to be like the next chapter on their walk. Like, that's just a really cool place to be. Um, so yeah, so folks, each setting has their unique challenge, not just clinically, but also emotionally and spiritually. And you can be angry at the world and happy at the world, but it's how we prep and see it. So,
Yeah, and to try not to leave it on, like, a sad, heavy note, um, I think that, I spend a lot of time I do a lot of yoga, I do a lot of things that kinda help ground me and help me kind of not get too caught up in when things are sad, but it also, while there are parts of working at the hospital that can be, heavy and sad, we also see a lot of really amazing recoveries and kids who you know, make huge progress, and those kind of like inspirational videos that see online of these really, really remarkable recoveries, those do happen. And I think, I was talking to one of the ENTs that I work with, who I think had a resident that was a little bogged down by some of the sad things that were happening with the patients that we were following at the time in the hospital. And we just talked about, like, kids are so resilient, and a lot of the time, even ones where you really think there's just no way they're going to get better than they do. So, um, yeah, there are a lot of amazing recoveries too.
okay, so my one of my very first patients ever, like a billion years ago, he had macrocephaly, hydrocephaly with a shunt, and we're talking like rural Virginia. And I saw him in an outpatient clinic at the hospital. He couldn't even get into early intervention because it was so rural, right? So I saw him for almost 2 years, and mom was like, I just don't know if he's ever going to talk. It's the only child I ever said, I don't know. And then she came back a week later and she goes, so guess what happened? She goes, I was changing, he was, 4 and change by now. She was trying clothes on in the, like, the dressing room. And she goes, and all of a sudden I hear a creepy old man saying, hey, baby. And she was like, what the hell? And like, it's a peeper, it's a peeping Tom. And, and no, it was the little guy. Cause we always said, hey, baby. But like
Yeah,
when he did speak, he had this little old man voice. And
so cute.
he chose right then. So, but that was it. And then it was like something clicked and then he just took off. And it was, I think back on that, I'm like, the only time I ever concurred, I just don't know if it's going to happen. And like, prove me wrong. It was great. But,
Kids are you just can't there's so much hope, and they do get better. I think even when, I see a lot of kids who are on ECMO and like as sick can be, and they do sometimes get better and are able to go on and live, normal lives. And I think that yeah, even though it can be hard, there's a lot of really happy, positive things that happen in this setting too. And we get to see a lot of really amazing recoveries. So
yes, but you have to choose it. And
yeah.
that's a choice. Yes. Okay. So if somebody wants to reach out to you, say they have extra questions, is there a contact that you can share?
Absolutely. Yeah, you can send me an email. My email is patten.hannah@mayo.edu, and it's Patten. And then my first name is Hannah. So yeah, feel free to reach out. I'm happy to chat.
Okay, now I'm going to put you on the spot because I didn't
Okay,
prep you with this beforehand.
sure.
But if somebody has any like love money or mad money, that's what my grandma would
Mhm.
call it, like
Yeah.
leftover, and they want to make a donation
Mhm.
because they're inspired by your words, what organization, entity? It could be Bob Barker's spaying and
Yeah.
neutering dogs. It could be all of the above.
Sure. Oh, I actually probably would say Feeding Matters. I turn a lot of my patients to Feeding Matters. I think that kids who have parents of kids who have feeding challenges feel sort of isolated, and I really direct them to it. And I think that, what I tell them is that, like, I've taken care of many kids that have feeding tubes, many kids that have dysphagia and feeding disorders, but I've never had my own child that has these things. And so I can't tell you anything from that perspective. And so I think the things that they do are really amazing. I know you like Feeding Matters too, so that's probably not, are very involved with them. But yeah, that's the one that kind of comes to mind that I point families to really regularly.
Yes. Oh God, I love them. So yes, great one. I just learned yesterday. I was interviewing Dr. Amy Talbot from Australia, and in Australia they have something called the Butterfly Foundation, and I thought it was for like butterflies, but it's an eating disorders like scholarship across Australia, but for PFD and ARFID, and I was like, That's cool. I hadn't heard of that one, but I was
Yeah.
like, "We've never supported butterflies before," and I got all excited, and then it went all the way over here, and I was like, "Oh, also equally exciting," but, like,
Yeah, yeah. Yeah.
not what I thought it was. But,
Mhm.
okay, well, Hannah, thank you so much for coming
You're
on,
welcome.
and, talk to your team. Let's get the
I will.
aerodigestive track people on, because
I
that's
would love to.
yes! Okay,
Yeah.
alright, folks, be sure to, check us out on First Bite and, Instagram and, Facebook, and you can find me on LinkedIn just under Michelle Dawson. So, huzzah! Hannah, thanks, hon.